In this video, you'll find out all you need to know about melanomas. We'll review the commonly taught ABCDE rules for identifying them, and I'll explain its two great flaws. I'll point out rookie mistakes that often trip people up. You'll learn melanoma-specific dermoscopic signs to look out for. Throughout, I'll be weaving the stories of patients I've diagnosed with melanomas over the last 10 years by way of illustration, with a quiz at the end to test you. And if that isn't enough to satisfy your thirst for knowledge, I'll be discussing algorithms, often promoted to help diagnose melanomas, and why. Hold on a second. I think they're a waste of time in general practice. If it wasn't for melanomas, there'll be little need for dermoscopy. 80% of skin cancer deaths are due to melanomas, with around 100,000 diagnosed in the US a year, resulting in around 9,000 deaths. In the UK, the figures are 17,500 diagnoses and 2,300 deaths. These numbers are rising and have risen by 150% since the 1990s. One of my favourite films growing up was called War Games, where a teenager accidentally hacks into a war simulating computer in the American military. He thinks he's playing just a cool game, but to those in the military defence department and the computer called Joshua, it's very real. Spoiler alert, as the computer works out all the possible outcomes in the game global thermonuclear war, it comes to this conclusion.
Strange game. The only winning move is not to play. How about a nice game of chess?
That is how the majority of my primary care colleagues play the deadly game called Catch a Melanoma. Not that chess is their preferred game, but they try not to play the game at all. They do this by referring to secondary care anything that possibly looks suspicious. What's wrong with that, you reasonably ask? It's because unlike with global nuclear war, it's a losing strategy. Some melanomas, like my first patient here, don't play by the rules. This 66-year-old came to see me with a 4-month history of this mark on his left palm. He'd tried various creams from the chemist and said at times it seemed to heal over, but would then break out again. What is it? Looks like a cigarette burn, I think, but being about 10 millimeters in diameter, that's one large cigarette. It was flat with a bit of a light scale on top. Perhaps dirty looking around the edges. There was no pain or a history of injury that he could remember. My mind thought about eczema, but eczema usually itches, and this wasn't that. Was it a fungal infection, I thought? If you aren't trained in dermoscopy, you could quite reasonably prescribe a steroid or antifungal cream, telling him to use it daily and come back in 3 to 4 weeks if it wasn't healing. However, using my dermoscope, this is what I saw. A good, clear, well-demarcated border, which is actually usually reassuring. However, there's a little bit of light scale. But more obvious are these large white areas and vessels at the edges, some even of the hairpin type. A little bit of brown smudging here. It was when I switched to a slightly deeper view using my polarised dermoscope light setting that I gasped. The whole area lit up with a multicoloured iridescence. Do not pass go. Refer ASAP. This is a melanoma, 3.8 millimeters deep and sentinel node biopsy positive on presentation. I'll explain the significance of those two facts as we go through this video. What I want you to think about now, however, is what would have happened in our high stakes game of Catch a Melanoma if you'd only dismissed him with a cream with instructions to come back later if it was no better. There'll be a delay, right? What would this melanoma have done in the meantime? His prognosis would have worsened. Learning dermoscopy is the only winning strategy. What is a melanoma? It's a skin cancer where cells called melanocytes start multiplying uncontrollably with no off switch. Their usual function is to produce the black pigment called melanin, which they inject into the main cell types within the skin called keratinocytes. This pigment acts like an umbrella, protecting the skin cell's DNA from being damaged by ultraviolet light. There are 4 types of melanoma, and knowing their habits will help you find them. 75% of all melanomas are of the superficial spreading type. They have a radial, horizontal growth phase within the skin that lasts for months or even years before they start to invade deeper into the skin. This is important because if caught at this earlier radial growth phase, a patient's chances of survival are much greater. Nodular melanomas account for 15%. These unfortunately skip that radial growth phase and they just start invading deeper into you from the go. Often black, but sometimes they do lose their ability to produce melanin, so are pink. In other words, a melanoma without any melanin, which we call an amelanotic melanoma. Acral melanomas, while only accounting for 5% of all melanomas, because the structure of the skin in acral places is different, melanomas also look different. Lentigo maligna melanoma, now that's a mouthful. Most common on sun-drenched skin, such as the face, the neck. Slow growing, they account for our final 5% of melanomas. If you struggle to remember these 4 types, check out my dermoscopic hack video here, where I liken melanomas to different types of big cat. Knowing who is most at risk of getting melanoma will help you find them. Let's start with skin type. The 1970 1975 Fitzpatrick skin classification is based on skin's response to ultraviolet light. Our different skin shades are due to how much melanin each melanocyte cell produces, and not their number. Because melanin protects against skin cancer, this is what we find. The most common cancers in the UK are breast, prostate, lung and bowel. The fifth most common is melanoma. It's the same in the US, but in Australia, the country with the highest rates of melanoma in the world, it beats lung and bowel cancer to number 3. What does this mean for an individual? The lifetime risk of a person with a lighter skin type developing a melanoma is around 1 in 40. And for those with the most protected skin, it's around 1 in 1,000, with a gradient in between. Let's turn this into a graph. But there is something odd about acral melanomas. They aren't caused by ultraviolet light. Therefore, the chances of you developing one is the same, whatever your skin type. In lighter skin types, they make up only around 5% of the melanoma types. But because of the increased melanin protection from darker skin types, this is what happens. If you have a dark skin type, overall your melanoma risk is less, but if you get a melanoma, it's more likely to be an acral type. Rookie mistake to avoid number 1. If a patient with a dark skin type comes to you, don't assume they can't get a melanoma, and be especially alert when there are new changes on the acral sites. This video takes a closer look at nail changes and how to spot a nail melanoma. What about age? Well, that seems clear. While the average age for a melanoma diagnosis is 61 years, they do occur in younger people. And because other cancers are very rare in this age group, melanomas account for a higher proportion and more years of life lost in this age group. Before puberty, they are incredibly rare. In fact, about as rare as my dog ignoring food dropped on the floor. Knowing this helped me reassure the family of this 6-year-old young girl who presented with this dark mark on her left lower lid. There's no family history of melanoma, and she had around 15 normal nevi in total on her body. Could it be a melanoma, doc? One thing that reassured me, no it's not, was her age. 12 months later I followed her up and it's unchanged. Where do melanomas occur on the body? The skin locations that melanomas prefer varies between the two sexes. For women, the majority are on the legs, and for men it's on the trunk. We can use this knowledge to our advantage. Up to 50% of melanomas are picked up by chance in this way. Why are melanomas so dangerous? It's because if they breach the base of the skin, in other words the basement membrane, they are very quick to seed throughout the body. The main route is through what's called the lymphatic drainage system, although the bloodstream can also be used. The most common sites for spread or metastases are the lymph nodes, lung and liver, but they can occur anywhere, including back in the skin somewhere. A lymph node is sometimes removed from the first lymph node draining fluid from the melanoma skin site, called the sentinel node. It's checked under a microscope to see if there is any melanoma in it. If even a trace is found, the patient's melanoma is called node positive. This is one of the 2 most important predictors of survival for a patient with melanoma. The second predictor of a long-term survival is the depth the melanoma has reached within the skin. This is called the Breslow thickness, named after a Dr. Alexander Breslow from George Washington Hospital in the USA. In 1970, he noticed the depth the melanoma invaded into the skin was an important predictor of the patient's chances of survival. I was struggling to remember this graph, so came up with this rhyming ditty. Less than 1, stick up the thumb. 1 to 2, squeaky shoe. 2 to 4, you've missed the door. 4 plus, toss a coin. How are we going to detect melanomas before they become too deep and dangerous? The most common system you may have been taught is the ABCDE rules. I'll review it now because it has its uses, but I then need to explain its 2 great flaws and how we can overcome them. A is for asymmetry. A harmless common mole is usually symmetrical, whereas melanomas are often asymmetric in shape and or colour. B is for border irregularity. A harmless common mole has smooth, even borders, whereas a melanoma often has irregular, blurry or jagged edges. Colour variability. A harmless common mole is usually 1 shade of colour, or 2 colours with one occurring inside the other. Melanomas can be brown, but can have as many as 5 or 6 different colours, such as blue, black, tan, grey, pink and red. 50% of melanomas include these uncommon colours. These colours are uneven or irregularly distributed. C is also for changing colour. D, diameter 6 mm, because the majority of harmless moles are smaller than 6 mm. However, of all these signs, this is the most controversial. Some have called it D for dogma, but more useful is calling D as different, something that stands out as different from other skin lesions on the patient's body, or what we call the ugly duckling sign. E is for evolving. A harmless common mole is usually stable and doesn't change in size, shape or colour, whereas a melanoma does. These changes can occur over months or even years. This system partly works because the majority of benign nevi are ABCDE negative. Does having more of these boxes ticked increase the chances of a melanoma being detected? The simple answer is yes. There's a link to the study in the video description below. What about flaws? Well, the first flaw is not all melanomas play by these rules. You can still have a melanoma with no boxes ticked. Flaw 2 is best explained with a graph. The more of these ABCDE criteria you tick, the greater the chances of that skin lesion being a melanoma. Diagnosing some melanomas can be made from the doorway. What do you make of this 87-year-old gentleman's scalp? How would you score it? It ticks 3 to 4 of our ABCDE. And as a gentleman at high risk for a melanoma, what would you do? Well, without a dermoscope, you'd refer him, I hope. This is what I saw on dermoscopy. It's a seborrheic keratosis, so I choose to reassure him and do nothing. But then a funny thing happened. A few months later, I discovered he'd recently seen a colleague of mine who referred him on the cancer care pathway as a potential melanoma. And at this point I thought, is this really a melanoma after all? And if so, perhaps I don't know what the heck I'm doing. Secondly, I was interested if secondary care would actually remove it. Press a button now on the screen. What do you think? Did they remove it or not? They removed it, and the diagnosis was seborrheic keratosis. What that means is that using the naked eye to evaluate a skin lesion as a potential melanoma, you will pick up many benign non-cancer skin lesions. These are called false positives. That's where you worry it's a melanoma, but it's not. Studies have shown that using the naked eye alone, we need to cut out around 18 non-cancers to make sure we don't miss that one that is a cancer. In my region of South Yorkshire in the UK, with a general population of 1.4 million, the local GPs like me in 1 year refer 14,000 skin lesions as possible melanomas. Do you know how many of those were actually skin cancers? Only 6%. And that's what you would expect, using only the naked eye and just these ABCDE rules alone. Is there any way we can counteract these 2 flaws and do better, do you think? Anyone? Please, someone. I hope you're now shouting at your screen with the answer. Studies have shown that using dermoscopy to screen out non-cancers, barring colleagues getting involved that is, reduces this benign skin cancer excision ratio down to 4 benign to 1 cancer, saving not just money but also much patient worry. The second way dermoscopy helps is this. Remember those low-scoring ABCDE melanoma lesions? Dermoscopy can often tell you it's a melanoma before you get a full house of signs that have developed. An early diagnosis of melanomas saves lives. It's time to show you some dermoscopy. But first, I need to tell you a joke. There was a couple out for a drive in the countryside. They became lost and eventually decided to ask the next person they saw. Seeing an old farmer standing by the side of the road, chewing on a straw, they slowed down and rolled down the window. "Excuse me, dear chap, can you help us with directions back to the city?" The old man thought and thought again before replying, "Well, if I was you, I wouldn't be starting from here." Teaching dermoscopy to identify melanomas is a bit like that. You shouldn't be starting with this video for 2 reasons. First, being able to identify and reassure patients that their skin lesion isn't a melanoma is most of what you'll be doing in primary care dermoscopy. Secondly, when you approach a skin lesion to see if it's a melanoma, your first question is, do I recognise what it is? If not, the next question should be, is it of melanocytic origin? And this video here will show you how to do that. Having said that, here's the plan. I'm now going to show you 8 melanoma-specific dermoscopic signs. In their order of importance, I think. You can download a summary in the video description below. Bear in mind that each sign has its own sensitivity and specificity, and also that this isn't a complete list. I'm then going to test you on a quiz with my patients. Your mission, should you choose to accept it, is to see how many of these melanoma-specific signs you'd recognise in each of my patients. Atypical pigment network. A normal pigment network pattern has lines that are similar in width and colour when the structure of the network lines are irregular in width and colour, and the size hole is also variable. This is called an atypical pigment network. Deciding if that network pattern is normal or atypical is down to practice, and it's an inexact science. These changes occur because the melanoma cells spread along the rete ridges, causing distorted thickening and changes to the network pattern. Irregular dots and globules. Regular aggregated dots and globules are a marker of a benign nevus. Irregular dots and globules, however, are balls or nests of pigmented nevi or possibly melanoma cells that vary in size, colour, and are distributed in an irregular manner throughout the lesion. Cancers are chaotic due to their very nature. Rookie mistake number 2 to avoid falling into is seeing small dark comedone-like openings in a seborrheic keratosis and thinking that they are irregular dots and globules. Learning to recognise a seb-K is therefore vital, and this video should help you. Shiny white lines. These are due to new or altered collagen within the papillary dermis. Therefore, you'll see them best on polarised dermoscopy. There are a few possible causes for shiny white structures in skin lesions, which is why dermatofibromas melanomas can look exactly like a melanoma, and especially if that dermatofibroma also has a peripheral pigment network pattern. Sometimes the only way to tell the difference is to cut it out and let the histopathologist decide. The shiny white structures in melanomas tend to be of the short white line type. This video here will explain more about shiny white structures. Peripheral tan structureless areas. Imagine a normal pigment network in a common nevus. Key fact: 80% of melanomas arise de novo on a new bit of skin and not within a nevus that is already present. A new mole in a person over the age of 45 should concern you most because this is very unusual. But imagine if our melanoma arises in a common reticular nevus. Sometimes the cancer cells don't follow the basement membrane, creating our atypical network we've already heard about. Rather, they just bulldoze through the ridges, erasing any signs of a network pattern, like this. Note, some common benign nevi and lentigos have a homogeneous structure, but this should be the same throughout the structure. Regression structures. When a melanoma starts spreading, sometimes the patient's immune system notices and produces an immune response against the melanoma cells, killing them. There are two types of regression structures to look out for. First of all, a scar-like depigmentation, and this is where the area should be very pale, paler than the surrounding skin being a clue. Secondly, peppering, which is the release of that melanin contained within macrophages, now called melanophages, or left free floating within the skin. You're actually more likely to see peppering in some non-cancerous skin lesions, in particular inflamed seborrheic keratosis, yes, them again, or solar lentigo. In melanomas, this process is usually partial, with some areas undergoing regression, while other areas of the cancer are expanding in size and mass. Regression structures are always flat and not raised above the skin surface. Blue-white veil is something that's often talked about when it comes to melanomas, but this is down on my list because usually it's something I recognise in retrospect. I'm often more convinced in hindsight, after it's proven to be a melanoma. You can get a blue-white hazy veil which appears over capillary hemangiomas, but there should be other signs of it being an angioma, and also that should cover the whole surface of the lesion. Blue-white veil is described as a structureless area of blue pigment with a ground glass haze over the top. It is due to hyperkeratinization over dense epidermal pigmentation. In melanomas, this blue-white veil only occurs over palpable raised areas and doesn't affect the full surface of the skin lesion, but is often focal and ill-defined. Peripheral streaks. Again, this is down on my list because I've never been fully convinced I've seen them before I've had the diagnosis. It's also, I think, another potential rookie error number 3, which in seborrheic keratosis at the edges where the fissures and ridges come to an end can look like streaks. Read the whole lesion and its patterns. Other clues should be there to tell you it's a SEB-K and not a melanocytic lesion. Negative network, formerly known as inverse network pattern. This is the development of lighter grid lines that connect between hyperpigmented globules and is found in around 1/3 of melanomas apparently. It also occurs, however, in intradermal nevi, usually over the whole surface of it, although other signs should give you that diagnosis, but they also occur in congenital nevi. If you've now got all those locked into your brain, it's time to test you. For each of these patients of mine, tick which of these melanoma-specific signs you can see in each. You'll get a 5-second warning, which looks like this, so you can press the pause button if you need more time. I'll then be giving you the answers and the final diagnosis. Are you ready? This 59-year-old lady came with a 6-month history of this lesion growing on her left lower leg. There was no family or past medical history of a melanoma. Which melanoma-specific signs can you see? Time for some answers. First off, just macroscopically, this looks very suspicious, ticking many of our ABCDE criteria. I was hoping when I looked at it on dermoscopy, it was just a seborrheic keratosis. Well, this isn't a seborrheic keratosis, unfortunately. It's very disorganised, which is the first clue, with irregular dots and globules, a peripheral tan structureless area, and the melanoma spreading out, destroying any rete ridges. I don't think this was pale enough for an area of regression, but certainly there's some blue-white veil being over the raised palpable area. This was a 1.2mm Breslow thickness melanoma, but a Sentinel node biopsy from her groin was positive. She's had no recurrence after 2 years. This 80-year-old gentleman came to see me having noticed this small lesion on his left outer thigh 3 months previously. It's only 4mm in diameter and he has no past history of any melanomas. Which melanoma-specific signs can you see?
You're ready for some thoughts? Despite being only 4mm in diameter, it actually ticks 2 or 3 of our ABCDEs. So let's see if the dermoscopy reassures us. It's of melanocytic origin because of the pigmented network pattern, but also there's some aggregated globules. These aren't comedone-like openings of a SEB-K because there are no other seborrheic keratosis features to see. Did you think the pigment network was atypical, however? It looks regular, but I'd call it atypical. These lines are thicker than normal and similar to the size of the holes, and it has a sudden cut-off at the edge. Even if you thought it was typical, these aggregated globules are atypical, varying in colour, size and just in one location. This is why you need a hybrid dermoscope. Note these shiny white lines flashing up. They are perpendicular to each other also. You can see them only on polarised light. Did you call this area a blue-white veil? Perhaps, and it probably is, being more noticeable on non-polarised dermoscopy, but the skin lesion was rather flat. On excision, this was an in situ melanoma, and it shows the power of dermoscopy to pick up an early melanoma when they are very small. Less than 1mm deep, stick up the thumb. Sentinel node biopsies are only offered where the melanoma is 1mm deep or more, or 0.8mm with other risk factors. This 78-year-old gentleman came to see me with this ugly lesion near his left eye. It hadn't changed over many years. His daughter was getting married soon, and he wanted it gone for the wedding photographs. He had no history of skin cancer, but his skin looked sun-bleached, so I did a quick skin survey of his back and found this on his neck. Which melanoma-specific signs can you see? These I recognised as comedone-like openings of a seborrheic keratosis, the long stable history being reassuring. I decided to give it a 20-second cryotherapy freeze, and here it is, 2 months later. He looked fine and handsome for his daughter's wedding. The skin lesion on his neck that he didn't know that he had. What do you think? It's got some pigment network here, so is melanocytic in origin, but it's very dark and atypical network here. If you said there's some streaks, I'll accept that. Is this regression? It could be, but it also could just be ultraviolet light skin damage. There were no shiny white structures on polarised dermoscopy that I could see. I had enough to refer him on the cancer care pathway as a possible melanoma, and it was a 0.5mm Breslow thickness melanoma. Less than 1, stick up the thumb. It was found by chance because I knew what I was looking for. Remember, around 50% of melanomas are picked up by chance by clinicians who bother to look. A 76-year-old lady came with a 9-month history of this slowly changing mole on her right shin. There was no personal or family history of melanoma. Which melanoma-specific signs can you see? The history of change, an irregular edge and asymmetry means we tick at least 3 of our ABCDEs, so it is suspicious. But does dermoscopy reassure us? Unfortunately not. I hope you by now recognise the widespread pigment network, meaning this is of melanocytic origin, but also look how atypical it is. There's large variable sized holes all over the place, larger and darker shades throughout. This is enough to consider this a melanoma until proven otherwise. For this to be a regression area, it needs to cover more than 10% of the surface area, and I don't think it is. This may be the start of some blue-white veil, but not enough to convince me. And on excision, this was an in situ melanoma.
Why not use an algorithm to help us in this task? Where's my antihistamines when I need them? I think I'm allergic to algorithms. Here's my favourite algorithm, which works in most of life situations. I avoid them for the following reason. 1, each algorithm has its own sensitivity and specificity. In other words, you can still miss a melanoma using them. 2, they are designed in secondary care on secondary care patients. So how valid are they in my primary care setting with a different population of patients with their different prevalences of disease and signs? 3, I see so few patients with melanomas. Am I going to be skilled enough to use one as accurately as a secondary care specialist who does this kind of work every day, day in and day out? 4thly, can I remember the scoring system when I need it, which won't be very often? If you're a fan of algorithms, then be my guest. Let me know in the comment section below if you agree or disagree with me about algorithms. Finally, what do you think of this? She's a 27-year-old lady with a long-standing mole on her tummy, but after a few months a dark area has been appearing within it. Let's score its ABCDE. So it's a concern. Dermoscopy shows this. It's a nevus with aggregated globules, proving that, but there's also a reticular network pattern. This can be a benign pattern. But is this atypical network here? Certainly it looks darker and different to that other bit of the network. As it was a new change, I referred her on the cancer care pathway. It was removed and the histology showed it was a dysplastic nevus. Hold on a minute. What are atypical or dysplastic nevi? And what are we to do with them? And if you don't know that, you'll need to watch this video next.
Training a primary care dermoscopist for every general practice.